afternoon, and thank you for joining us. The Delta variant is taking hold here in Nebraska and around the nation. So we're getting a lot of questions from you regarding COVID-19. So we want to take those to one of our experts. Dr. Kelly Cawcutt is back with us. She is one of our infectious disease specialists as well as a critical care doctor. So Dr. Cawcutt, thank you so much for taking the time today. We have a lot of questions for you.
Oh, thank you so much for having me again. And I'm happy to be here and will do my best to answer all the questions.
All right, you can post your questions in the comments. We have a list that are pre-submitted, some of the ones that you've been giving us on Facebook and through our website, but we will be keeping an eye on those as well. And just a reminder, this is a live chat. It's for informational purposes only. If you have any questions specific to your own health or medical condition, you want to go ahead and ask those to your primary care provider. Okay, let's get started because Delta is the word that's flying around, even though we know also Mu, the next variant, is kind of on the horizon. But what makes Delta so bad?
Sure, so that's a great question. And what we've seen with the Delta variant is one, it has really overtaken everywhere as the main variant of COVID-19 infections. And we do get that testing when we do our tests, and we look at that at the state lab. And of course, many labs across the country are looking at that too to confirm that information. And what we've seen is a few things. One is it is more contagious than the last strain or variant, if you will, that was going around and circulating, which was really more so the Alpha variant. And we're looking at a significant difference in infectivity. So one infected person could infect, somewhere in the realms of 7 to 9 other people. With that information, we've also added in new data that shows that although the vaccines still do what they were intended to do, which is to protect people from severe illness from COVID-19, so preventing people from being in the hospital or from being in such respiratory distress that they require mechanical ventilation or a breathing machine, we do now see that it does not necessarily prevent infection in the same way as it did for Alpha. So people who get exposed to the Delta variant, who are already fully vaccinated, can in fact develop a Delta infection. Again, the vast majority of these being very mild or asymptomatic, but they can theoretically transmit that infection to other people around them, especially those who are unvaccinated. And so that is why we've seen some of the changes that have come forward with what feels like stepping back in time on suggesting mask use again, especially because of needing to protect our unvaccinated community members and family members, and why there's been so much discussion about the vaccines and are they working or not. And I just want to reiterate, they still work very effectively at preventing severe disease and death from COVID-19 and the use of those mechanical ventilators that we've talked so much about throughout this entire pandemic.
Who is being the most significantly impacted by Delta?
So the Delta variant has very clearly impacted those who are unvaccinated primarily. And this also includes people who have had COVID before. So when you look at the data here in the state of Nebraska and you look at the data across the country, what we see is the vast majority of people who are becoming ill and hospitalized, so again, that most severe level of illness, it really falls into the unvaccinated category. And we've also seen a shift in age. So along with more of our older patients actually being vaccinated at this point, we've seen younger ages where there's a less vaccine uptake now coming into the hospital with significant illness. And we've also, of course, seen more pediatric cases as we see reported by many of our local children's hospitals and clinics and has been reported kind of nationally. But the pediatric data is still clearly in evolution, especially with so many places just starting school and looking towards what ultimately will happen amongst that group of patients.
I think it's alarming for those of us who are parents that have small children, maybe that are too young to be vaccinated. It looked like early on with the original strain that there was some protection to keep from spreading it. Is it true that we're not seeing as much of that with Delta? And then for those of us who are vaccinated, what can we do to help make sure that we're not spreading it even though we are vaccinated?
Yeah, so it's a great question, and certainly something that has been a point of discussion and debate for myself and many of my colleagues who do have small children who are not in the age range who can be vaccinated. And we are seeing that children can certainly spread these infections. And I mean, in the news, we've seen multiple school districts across the country having to shut down classes or full schools because of larger outbreaks. So again, still significant concern that they can spread this virus. Now, children are a little different than adults. If I cough and sneeze, I can spread aerosol and droplets farther than my 5-year-old or 6-year-old child can at home, right? And that's just a matter of body mechanics. So there's still going to be some variation there, but I think remembering that close contact, kids still have a capacity to spread the virus. Thankfully, we do see that most kids, again, the majority of kids do okay with this infection, but there are certainly reports of increasing hospitalizations with pediatric patients and rising numbers of children in that 0 to 18 age range compared to prior variants that we've seen in the historical context of this pandemic. So certainly a different impact there. There's also more pediatric patients, frankly, who they are seeing with more of a post-COVID or long hauler syndrome after acute infection. So realizing the spectrum is significant and that there's potential to spread, potential to get this infection, and some potential for long-term consequences. And that really kind of paves the way into the discussion of what do we do about that. Now, I understand that some of the discussions around this are extraordinarily contentious right now. But what we have seen and what we have said from the beginning of this pandemic are that we know that hand hygiene, social distancing, and mask use make a difference. That is why the CDC has made those recommendations, and there's been increasing evidence to show and support that that can decrease transmission. In addition, if you have the capacity to get vaccinated, even though you can still get infected and transmit the infection, you have a lower likelihood than someone who's unvaccinated to do so. And so by getting vaccinated, you help decrease the risk of transmission to those people who may be vulnerable in your life. And again, whether it's children, whether you have family members who've opted to not be vaccinated, and especially family members who may not be vaccinated and have other medical conditions that put them at high risk.
Since we were just talking about kids, one question that came in, we know that RSV is running rampant in the community and has been as well. Is there an easy way to distinguish between the symptoms of the two, or do you just really need to go see a doctor?
It's really hard to distinguish the symptoms between RSV infections and COVID-19 infections. And in the past, it was really hard to tell the difference between that and influenza. And because we can see such a spectrum of illness related to viruses, it really is something for which we'd ideally want people to be tested so that we know what we're dealing with. And I think that's also an important piece to note that, RSV has been running rampant again, and we're seeing this uptick of, viruses that we haven't seen when there were substantially more mask mandates in the past. And so we're certainly seeing shifts there. And that becomes important both for the confusion of telling the difference between symptoms, but also because these other viruses still cause a percentage of people to be hospitalized, right? And that still becomes an issue when our hospitals are remaining at very high capacity. And so doing everything we can to make sure that we have hospital beds when our patients need them remains critically important, both for adults and for kids.
We were talking about bringing back some of those things that we were doing earlier in the pandemic, more mask wearing, more hand hygiene. It seems like all the stores don't have, hand sanitizers every 3 feet like they used to. Some people say if we're doing this all the time, aren't we hurting our own immune systems? That's an argument we've heard a lot and a question we get asked a lot. How do you answer that question?
Sure. So your immune system is not getting harmed by not being exposed to continual viruses or germs necessarily, right? And you actually do have immune system impact when you do get an infection. And that has been true for this virus and a multitude of viruses because your immune system's busy responding to one thing and may not be able to respond to all the other things. But in general, our immune system responds quickly to new pathogens. It doesn't weaken over time. And if you've been exposed to other viruses, again, thinking about RSV or something like that's more familiar to people like chickenpox, right? If you've had some exposures in the past, your immune system doesn't forget that all the time. Now, that's not true of all infections, and I think that's a really important piece here. So when we talk about strength or weaknesses of immune systems, we need to realize that our immune system does not interact with each type of bacteria or virus in the same way. Some things do cause lasting immunity for essentially life. Some things like influenza or tetanus do not. And so recognizing that there's differences, and that doesn't mean that immune systems are stronger or weaker, are really important concepts, I think, to understand as we talk about that. Now, in addition, we know that hand washing helps people stay healthy and prevents other infections. And that's been a standard well before this pandemic. And hand hygiene is very, very similar, with a hand sanitizer in comparison to thinking about washing your hands, right? And we've always believed and known and seen data to show that that has a positive impact for overall health, but not necessarily a negative impact for the immune system.
Going back to the hospitalizations that we're seeing from COVID-19 right now here in Nebraska and across the country, I think people have heard a lot of those numbers, incredibly high numbers of hospitalized patients being unvaccinated. We're seeing that, but some immunocompromised people are also being hospitalized as well. Can you talk about kind of those two groups, and then also why immunocompromised people may be at risk and what we can do to protect them as well?
Sure. So there's multiple aspects to that question. So let me try to tackle these piece by piece. So first, yes, we do absolutely see that difference in unvaccinated versus vaccinated persons with hospitalizations. So for instance, I've most recently heard that if you look across Nebraska at the different hospital systems and counties, we're looking at an 8 to 18-fold difference increase in hospitalizations amongst the unvaccinated compared to the vaccinated. That's similar to data that's been reported from other states and nationally. It is a significant difference. And I think it's also important to note that we now have seen that that is true even for people who have had prior COVID and have deferred vaccination because they thought natural immunity was going to be strong enough to prevent reinfection. So a recent study out of Kentucky still demonstrated that having a prior COVID infection diagnosed was not as protective as vaccines, with over twofold differences in comparison to hospitalizations. So that just adds to some of the data we've seen on overall immunity, and that the vaccines do continue to provide one of the highest levels of protection we have for severe illness and hospitalization. Now, when we transition that discussion to more immunocompromised patients, things are a little different. And they're different for COVID-19, but they've been different for other vaccines in the past also. And that is because many of these patients, either due to the condition that they have at baseline that causes their immunocompromised status, or because, say, they've had an organ transplant and are taking medications that make them more immunocompromised. Whichever the reason is, their immune system is suppressed. And when that happens, they don't tend to have as robust of an immune response to vaccines. Again, we've seen this in the past with other vaccines that we've used in these patients. And so that was one of the main areas of interest. And we certainly did start to see some of these immunocompromised patients still getting reinfected even after vaccines, still ending up in the hospital. Now, that is one of the things that also leads to the idea of giving a third dose of a vaccine, such as a booster, where data has shown that the immune system response after that third dose, even in the immunocompromised population, is much more optimal, and they do respond in a more effective way. And so really the things that we need to do are, one, again, protect our friends, family, and community members who are immunocompromised by doing our best to wear masks, wash our hands, and prevent our inadvertent transmission to them. That happens both with those pieces and by ourselves being vaccinated, and also encouraging our immunocompromised patients and, again, friends and family members to be vaccinated and to go ahead and proceed to that third dose.
We have a large population of patients that we see here at Nebraska Medicine that follow this Facebook page, who do fall in those categories, who have received an organ transplant or who have a family member that do. And I think it can be frustrating for them to think that they're not boosting as strong of a response, but something is better than nothing. Is that a good way to describe it, even though it may not be as strong as what the rest of us see?
Right. So one, yes, something is better than nothing. And we need to remember that the antibody response is only one part of the response that we talk about when we give a vaccine. There are other parts of our immune system that also respond to infection, that have memory, that help provide immunity. Two, we have a high population of immunocompromised patients who've been vaccinated who have not ended up in the hospital yet, right? So we're seeing effect of the vaccine, but we want to make sure that because we do see that larger proportion of breakthrough infections, especially now with Delta, that we provide as much protection as we can and try to give them that boost up so that they have as much immune response as they're able to mount based on their medications and medical conditions.
You touched on briefly this natural immunity versus the immunity that you get from the vaccine, which is something I've been getting a ton of questions about. Doesn't that work the same way though? Even if you're getting a boost of natural immunity, why not get vaccinated as well to get as much protection as you can?
Right, so it's a great question. And I think this kind of leans back to that discussion we had a little earlier that not all infections provide the same level of what people are considering natural immunity, right? So again, if we think about the idea of chickenpox, right? So if you were of the age where you got vaccinated and didn't have initial chickenpox, we consider those vaccines essentially to be lifelong immunity, right? But take something like tetanus or influenza, we don't. We also have other viruses, like other coronaviruses that circulate seasonally every year that have been here for a long time that we know we don't mount the same kind of lifelong natural immunity to. That immunity wanes over time. And that is what we see with this virus. So yes, if you have had COVID-19, will you mount an immune response? Yes. Does it seem to be as strong, as long lasting, and as effective at preventing you from getting new infections or becoming in the hospital compared to these vaccines? No, it does not. Does it potentially increase your response to the vaccines if you've had it and then you get vaccinated? There's some data that suggests that you might have an even better immune response compared to someone who's never had COVID. But again, the highest level of protection and the longest lasting protection as of right now is to be vaccinated, which is why the recommendations remain that even having COVID-19 in the past does not mean you should not get vaccinated. It is still recommended to receive one of the approved EUA or full FDA approval of Pfizer vaccines for protection to try to help keep you from getting ill.
I think that's a really good analogy because if I step on a rusty nail, I'm going to go ahead and get that tetanus shot. I'm not going to complain that why does the tetanus shot so bad that my first one didn't last a lifetime? So it's important to know that as we learn more, these recommendations change. So I think that's helpful. Something else.
Yeah. One other thing I would just add is one of the questions has been, but why do I need multiple vaccines if they work? And I just want to touch on that too, because this is not the first time we've seen this either. If you think of hepatitis A or hepatitis V virus vaccines, they were vaccines given in several doses over the course of a year. And that is how we generate that immunity. So it's a very similar concept to what we are seeing now. This is not a new concept with vaccines, but I think because of the pandemic and all of the questions that have surrounded this, it is something that often we lose sight of and don't remember that that is the way some of these other vaccines for viruses have worked historically.
Something else we hear a lot about are adverse reactions to the vaccines. If anybody goes looking for them on the internet, you can certainly find plenty of those. How do you reassure someone who has seen a lot of those stories, who's actually more concerned about having an adverse reaction than they are scared of getting COVID itself?
So that's a really great question. And I think one, we all need to approach any discussion about vaccines or COVID, which is with as much capacity to listen, to understand what fears people have are and what they've read and what they've been exposed to. And we also need to recognize there is an astronomical amount of information out there. And there's information that is being put out by people who sound very smart, who have different credentials, that may lend themselves to thinking that they really are interpreting the information or have the clinical expertise that may not. And that makes it really hard to tell who to believe. And I've heard that from patients over and over again. How do I know if I'm getting good information? Who do I look to? Who do I trust? And how do I make these really hard decisions when there's so much information out there? So one, please understand that with the millions of vaccines that have been given, the overall confirmed adverse events are actually quite low. And for many of the things that you may read about that people had reported anecdotally, their own experience or someone they know, there's a lot of those reactions that may be unfortunate coincidence of timing, but not necessarily related to the vaccine. And this is something that also is really important when people talk about the CDC VAERS program and reporting vaccine adverse events. So when I, as a physician or a patient or anyone else is trying to report an adverse event, we are not trying to prove that the vaccine caused it. We are submitting information about an event that happened so that when the general population of everyone who's getting the vaccines is reviewed, they can look to see, is there a trend of these? Is it statistically significantly higher than historical baselines before COVID-19? And if it's not, if you're not seeing an increase with it amongst millions of people, that is where some of these subsequent follow-ups that said, no, it's not associated with some of these other conditions have really come forward. Or where some of the questions have come forward and said, yes, there is an increased risk of clotting, in certain populations with the J&J vaccine. And so VAERS reports a ton of information, but it doesn't necessarily mean those are all actually related to the vaccine. If I wanted to, for instance, I could go in and report getting a vaccine and 2 days later being in a car accident. And I could say that, I didn't feel well and the car accident was because of my vaccine. Now that's an extreme example, but it's an example of how open the system is for us to report information to try and make sure that we look for any signals that there really are long-term or significant adverse events.
You aren't just some internet doctor, you're a real critical care doctor who's seeing and treating patients. The controversies about treatments for COVID patients, we hear a lot of people saying, oh, well, it's true that hydroxychloroquine works, or now ivermectin has been a huge thing in the news too.
Yeah.
How do you combat when there's this huge kind of rage of news about these kinds of topics when you know what really works because you're seeing the patients?
Right, so that's a great question. And this also becomes extremely difficult because there's a few things that are important to recognize. One is there are ongoing studies trying to demonstrate what treatments actually help people prevent COVID, treat COVID as an outpatient, or treat COVID in the hospital. And these studies are really what we use for our evidence base to make the best decisions we can for the patient in front of us. Now, there are healthcare workers, including physicians, who advocate for treatments that are not proven to be effective. And that really aids in the confusion and some of the experiences that we're seeing our patients have when they're trying to understand why people are or are not giving certain treatments. Ivermectin actually was brought forward very early. I think one of my first talks about treatments back in early spring 2020 talked about ivermectin because it was brought up right away back then. And all of the studies that have been well done, high quality medical studies in humans do not show that ivermectin is effective in treating COVID at any stage. And I can promise you, we all want to find the things that will help people get through this, but we don't want to give anything that's not effective because then all I'm doing is giving something that has a risk of adverse events. And so we look at that and we rely very heavily on the evidence base, as we have always in medicine, trying to rely on evidence to make the best decisions on treatments for patients. That is echoed by our national societies, both with the National Institutes of Health, the CDC, even the FDA coming out, and the Infectious Diseases Society of America. None of our standard guidelines that help guide expert therapy by review of the literature and science have recommended ivermectin for any type of treatment unless it is being reviewed in the context of a clinical study. That means that unless you are enrolled in a study at a facility that is sponsoring it, it is not recommended whatsoever for routine therapy.
But all the doctors are looking for all the treatments and doing those full clinical studies. And that's a point that we've tried to make to everyone out there again and again. Some of the questions that have been coming in have been related to getting a third dose. For people who have various medical conditions, is the best advice on that just to talk to their primary care provider to determine if they should be getting one?
Yes, so there's clear criteria within the EUA that came out for these third doses for Pfizer and Moderna on they're coming out with this information on who right now is there a recommendation for. And really, we're looking at people with significant immunocompromise, and there's a list of criteria that you can review with your doctor on whether or not you meet those criteria. Now, there's also been a lot of discussion about a date of September 20th, with perhaps hearing further guidance on whether third doses would be recommended for the general public. That data is not data that I have had access to see. It is not something that we know of a formal decision-making meeting coming yet, but I expect we will absolutely hear more about the additional questions of if we will proceed to those third doses by the end of the month.
Something else we've heard a lot about is hospital capacity and people pointing out that hospitals had greater numbers of COVID patients back in the fall around November. So it's not as big of an issue. However, hospital capacity in general is very high. Can you just put some perspective onto why this is a big deal?
Yeah, so absolutely true. We do not have the same number of COVID patients in the hospital right now that we have seen at our highest peaks. But we are still, at least at our organization, looking at 50 to 60 patients in the hospital, taking a hospital bed for COVID-19 on a given day right now. And we have also had a very full hospital filled with non-COVID patients, as we've seen around the country. And there's a multitude of reasons for that, including the fact that many organizations shut down procedures, limited clinic visits, and really had some issues with, deferring care early in the pandemic when we saw the height of those patients in the hospital. And those patients still need care, and that care was delayed. So we do have some patients who, may have had progression of illness or worsening of disease that lead to hospitalizations, but we've just seen a huge requirement of hospital beds for non-COVID related disease also. And that is further augmented by the fact that this pandemic has been extraordinarily hard in unprecedented ways on the healthcare workforce. We have seen the loss both to COVID-19 illness and death, and also people leaving the workforce because of the strain and stress and burnout that has come from working in a high-risk pandemic with limited resources and really working more than any of us had planned for what has been truly a marathon of a pandemic. And so when you mix the idea of a strained workforce with a really full hospital system, even if I have another open bed or two, which many places don't, but if there's no staff to take care of a patient in that room, that patient's still not going to get care. And so I think it's really important to understand there's many pieces there. If we limit the number of COVID-19 patients coming into the hospital, those are beds that we have for patients who have non-COVID diseases. So this is not, although we talk about this being in part due to COVID, it's not just COVID, but for every hospitalization we can prevent, it's one more patient that we can accept into the hospital. It's one less story on the news of a patient who couldn't get transferred in time.
Strokes, heart attacks, those things are still happening at exactly the same rate, and we still need to have capacity for those patients. So one more thing I want to touch on that you kind of started talking to there is we talked about how things are kind of reversing. Here at Nebraska Medical Center, the main hospital campus, we had gotten up to 10 units full of COVID patients at one time. And we've got all the way back down to 1. And now those numbers are ticking up again. And we're seeing our nurses, our doctors, our medical assistants who had kind of thought that there was light at the end of the tunnel going through this all over again. And it's tough. And there's the mental strain of they're seeing these patients that are so sick, but there doesn't seem to be as much from the community to support healthcare heroes. Can you speak to just what we can do to support those of you who are going through this again?
Yeah, so I think that's an extremely good point. And I think, you'll find varying opinions on being called heroes at this point, because we want everyone to be their own hero and to help do what we can to protect hospital capacity, to protect each individual, and to try to minimize the burden of this disease in our community and state. It is absolutely true that the healthcare workforce is exhausted and struggling from heavy workloads and burden to high acuity patients, to being overstretched, many times, and really with very, very little reprieve to recover and try to continue to respond. And I think that everybody is tired of the pandemic, right? Like, none of us want to keep talking about COVID-19. None of us want to be doing this again. And I think that makes it really hard to continue to support efforts to try to prevent it, because it feels like we've been doing it forever and it doesn't work. But we know it does, because we did get down to lower numbers, to 1 unit, to having enough hospital capacity. And I think recognizing the fact that there is substantial strain, and also recognizing the fact that we definitely are hearing people tell us, this is what you signed up for when you took this job. What I can tell you with full certainty is there's not a person in healthcare who signed up to do this like this, and not just taking care of patients, but to manage the emotional and mental toll that has come with the pandemic and the workload, because it's nothing like we've ever seen in medicine before. We struggle with trying to help provide the right information and accurate information to the best of our ability. When information is coming up quickly, some of it's good, some of it's bad, some of it's somewhere in between, and trying to combat that. And trying to manage this in our own personal lives too. COVID doesn't go away when we leave our jobs. We're faced with it at home and with our families and friends and colleagues. And some of those interactions are frankly very hard right now. And so I think, one, if you know someone in healthcare, please recognize that you need to give them grace. They are doing the best they can. 2, recognize that saying thank you means so much to these teams. Hearing that they're valued and that they are making a difference when some days it doesn't feel like it is also incredibly important. And I think, anything you can do to help support, our staff, our nurses are extremely stretched right now and are doing amazing jobs, as are our respiratory therapists and our physical therapists and, our environmental services workers. Everybody in this hospital and in all of the healthcare systems is really trying to go above and beyond to keep providing care, and everybody's job is important. So saying thank you, showing appreciation, doing anything you can. And I will, on that note, also put in the plug for the fact that if you aren't aware, September is Women in Medicine Month. And I know Nebraska Medicine has been highlighting different women in medicine for the organization, but it's also a great month to really reach out to some of the women in medicine in addition, and really recognize that and support that. And however you can do that, I think is fantastic. It doesn't take much. Nobody's looking for huge gestures necessarily all the time, but they want to know that they matter. They want to know that they're seen, and they want a break.
I think that's a great opportunity. We've been highlighting some of those doctors on our Facebook page, and if there's one that you recognize that you had great care from, they do check these things and they like seeing that you remembered them. So I want to say thank you very much to you, Dr. Cawcutt. It doesn't mean as much coming from me because I text you thank you on a daily basis for helping me with projects, but it's important for the people watching to know that you're in there with the patients, you're talking to the families, but you and our other healthcare providers here at Nebraska Medicine and UNMC are also doing the research. You're writing the papers. You're not locked off in a tower somewhere completely separate from what this actual experience is. So what you say and the advice you bring, and acknowledging the fact that this information is coming in fast and you're doing your best to communicate it as best as you can. We appreciate the transparency. We appreciate your time. And we thank you so much.
Well, thank you guys so much. And to everybody who is listening, who came into this curious, looking for information, I really hope this was helpful for you. I hope that no matter what opinion you have coming into this, that you know that we are doing our best to provide absolutely the most accurate information that we can from the medical community to you guys. So thank you.
Thank you. And if you're looking for further information, Dr. Cawcutt and all of our providers are constantly providing articles at nebraskamed.com/COVID. You can submit anonymous questions there, and we should probably be back within a couple weeks to have one of these conversations again, because we know you have a lot of questions and we're doing our best to get them answered. So thank you again.